Thank you. Terrific. Hi, everyone, and welcome. We're really pleased that you could join us today for this results webinar for Stroke Foundation's National Rehabilitation Audit 2024. I'm Melita Stirling, the Quality Improvement Manager at the Stroke Foundation. I'll be handing over shortly to my colleague Anne Hooper, our audit coordinator, who has done a brilliant job of working with many of you who are online today and other clinicians across the country, and also our wonderful colleagues at Monash who do the data analysis for the audit. Anne will be presenting the resulting data for the audit today, and the data paint a sombre picture of stroke rehabilitation in Australia. Anne will then lead a discussion with our distinguished panel, who we'll introduce to you shortly, and we'll hear their interpretations and insights of these data and explore potential mechanisms for improvement to systems of care and processes, and most importantly, to work towards better patient outcomes. So I'll just start with a spot of housekeeping. We do have a really large number of people online today, so we ask that you keep your cameras and mics off, please, unless you're invited to unmute at the end in the panel discussion. Please do make good use of the Q&A, and we'll do our best to reply either in the Q&A section or in the panel discussion. And I will now, without further ado, hand over to Anne, who will take you through the results. Thanks so much, Anne.
Thanks so much, Mel. Can I just double check, Mel, that that we are recording? It was set to do it automatically, but I just want to double check that that has worked.
It appears to be, yes.
Perfect. All right. Thank you so much. So the Stroke Foundation respectfully acknowledges the traditional owners and custodians of country throughout Australia, and acknowledges their continuing connection to land, water, sky, and community. We pay our respect to the peoples, cultures, and elders past and present. They hold the memories, culture, and hope of our peoples. I would also like to acknowledge that I am joining you today from the lands of the Yuwibara people here in Mackay. So today we will take a look at the different components of the audit and different ways of cutting the data to gain an understanding of different facets of rehab. And then we're going to move to a discussion on some of the priority areas for change. Now, I'm sure most of you online today would be familiar with our amazing panelists, but for those of you who don't know them, I'm just going to introduce them to you. So panelists, if you could please turn your cameras on just while I introduce you. So we'll just start with Professor Natasha Lannin. Natasha holds a joint appointment as Professor of Occupational Therapy across Alfred Health and Professor of Neuroscience in the School of Translational Medicine at Monash University. Natasha leads the Brain Recovery and Rehabilitation Research Group, and her research team works with people to improve long-term outcomes after neurological damage, in particular from stroke and traumatic brain injury. She is an international expert in her field of neurorehab, where she leads large clinical trials that generate new evidence and implementation studies which translate evidence into practice on a national and international scale. Natasha is a current Heart Foundation Future Leader and a member of the Australia Stroke Coalition representing her profession. Oh, sorry. So thank you, Natasha, for joining us today. Dr. Tamina Levy is a physiotherapist with over 35 years clinical experience in neurological rehab. She works in the Advanced Practitioner Neurological Rehabilitation role at FMC-RAP and as a senior lecturer and researcher at Flinders University. Tam's area of research interest is around developing and implementing evidence-based rehabilitation programs for people with chronic neurological conditions with a focus on behaviour change. She applies her knowledge across fields of clinical, teaching and research, and her expertise is in stroke rehabilitation, especially around spasticity management and gait re-education. Welcome, Tam. And Kelvin Hill, who I'd be amazed if there's anybody online today who doesn't know Kelvin. Kelvin is the National Manager Stroke Treatment at Stroke Foundation, where he oversees the development and implementation of the Australian Living Stroke Guidelines, the National Stroke Audit, and other national clinical and policy activity. He's also actively involved in national and international efforts to improve guideline methods and their implementation. So welcome, Kelvin, and thank you to all three of you for agreeing to participate in our webinar today. So before I get into the results of this audit, I'd like to start by thanking each and every one of you who participated in this year's audit. Having completed both the acute and rehab audit several times over the years, I know how painful it can feel, particularly this rehab audit. The date starts to loom large on your calendar. You wonder how on earth you're going to get it done and still complete all the other tasks that are being asked of you. Who are you going to rope in to help you? Or are you going to grin and bear it and complete it by yourself? Then the audit starts. The weeks go by, you tick off your list of records, and then, thankfully, it's over. You can breathe again. So why do we do it? It's not mandatory. We choose to participate, and we do it for this. The opportunity to be able to review not only individual performance, but to benchmark performance against other services and find ways to improve the care that you're all so passionate about providing. So this is the 9th rehabilitation audit that's been completed. They've taken place biannually since 2008, although there was no audit in 2022 due to the impacts of the ongoing COVID pandemic, and also the audit program underwent an external review. As many of you know, the audit is comprised of 2 parts, the organisational survey and the clinical audit. The organisational survey provides information about the resources available to deliver rehabilitation care, such as the availability of activity levels, treatment, goal setting, and interdisciplinary staff. The questions assess the adherence to the National Rehabilitation Stroke Services Framework, which provides national recommendations for infrastructure, principles, and models of stroke rehab. The clinical audit involves the retrospective review of up to 40 consecutive episodes of care for patients with stroke. Eligible patients must be admitted to and discharged from the participating service between the 1st of January and the 31st of December from 2023. The clinical audit is used to measure the adherence to evidence-based processes of care, such as timely assessments by clinicians, interdisciplinary care, secondary prevention, and discharge planning, all of which have recommendations in the clinical guidelines. The audit is a mechanism for collecting data so that we can review our clinical resourcing and practice and be constantly striving to improve patient care. So let's have a look now at who participated in the audit this year. We had 103 rehabilitation services taking part in the stroke audit, and for the first time, all states and territories were represented in the rehab audit, which is fantastic. For the organisational survey, we had 92 public services represented and 11 private services. For the clinical audit, 85 public services took part and 8 private services took part. The participating services reported just under 9,000 admissions nationally, with 72% of admissions in major cities, 22% of admissions in inner regional areas, and 6% in outer regional and remote areas. For many clinicians, it was their first time being involved in the rehab audit, mainly because of the big gap of 4 years since the last audit cycle. So it was definitely a big learning curve for a lot of people. And I'm really grateful to everybody who took the time to understand what was required and put so much effort and commitment into completing the audit. So there's quite a lot of information at first glance on this slide, but this graph just shows the number of inpatient rehab services who participated in the rehab audit over the last 6 cycles from 2012 through to 2024. The dark blue columns show the number of services who did the org survey, and the green columns show participation in the clinical audit, with the total number of patient episodes audited running along the yellow line along the top. Despite the dip in 2020 due to COVID, there was a significant increase, as you can see, in episodes audited this year. So we had a really good representative sample of data from the 2023 calendar year, and it actually represents approximately 34% of the reported admissions from 2023. As this was our first audit post-COVID, we took the opportunity to ask services about the ongoing impact, if any, of COVID. And what we've seen in the results is that 20% of services are still not back to their pre-pandemic structure and resources. Redeployment of staff was reported by 63% of services, with nursing being listed as the main discipline affected. The main reason for redeployment was reported as shortages in other departments, and 25% of services are still reporting ongoing staff redeployments. So we asked 20 questions in the organisational survey about resources and organised systems for care. And those questions address these 10 elements which are outlined in the stroke rehabilitation framework, which you can see on this current slide. And what we're looking for is ideally all 10 of these elements are present in order to support stroke care and inpatient rehab. So let's get into the organisational survey results, and we'll start with the framework elements. 3 services across the country met all 10 elements, with 1 in 3 services meeting less than half the elements of the framework. You can see in the slide here, the national median was 6 framework elements met, which is actually the same as it was in 2020. And you'll see that trend throughout this year's audit results. There really has been minimal change across the board since 2020. Over the next few slides, I'm going to go through some of the key results from the org survey, and I'm going to start with the standardised and early assessment for rehabilitation. So this framework element looks at having a standardised process for assessing suitability for inpatient rehab and the timing of that assessment. So nationally, 55% of services met the requirements for this element of the framework. When we break that down, 92% of services reported having a standardised process in place for assessing suitability for inpatient rehab, but only 39% of services completed that assessment within the first 3 to 4 days of the acute admission. And we know that good links between acute and rehab hospitals and effective processes for those assessments are so vital for ensuring access to appropriate rehab for those who need it. So there is definitely more work for us all to do in this space. So next, we're going to look at the makeup of the rehab team and access to specialist stroke education. The questions relating to this framework element identify which disciplines are involved in stroke rehab and whether specialist stroke education is available for staff. So you can see on here, there's quite a variation across the states, with the national result at 68%, which, as you guessed it, is the same as it was in 2020. 30% of rehabilitation services reported no access to a program of continuing education for staff to develop their knowledge in the latest evidence-based stroke care recommendations. We added a new question in this year about communication partner training for staff who work with patients with aphasia. We know that this is a really important skill to allow patients to participate better in all therapies and to get additional opportunities for communicating with skilled partners. But only 49% of services provided communication partner training, indicating a significant gap in staff education that is really so crucial for supporting patients with aphasia. The figure here shows the average time that patients with motor impairments undertake active physical therapy per day, and this relates specifically to physiotherapy and occupational therapy. In the clinical guidelines, the recommendation is that patients be provided with as much therapy as possible, with a minimum of 3 hours of scheduled practice, involving at least 2 hours of actual active practice each weekday for physical therapy, and as much therapy for dysphagia or communication difficulties as can be tolerated. Despite the known benefits of increased therapy time, only 62% of services reported documented processes and systems to ensure patients received recommended intensity of practice related to their goals, with just 23% providing 3 or more hours of active therapy daily. The average therapy time remained at only 10 hours per week, significantly lower than the recommended levels, and again, the same as in 2020, which really continues to highlight the impact of the ongoing resource implications in inpatient rehab services. And we're going to come back to this issue in our panel discussion and consider what the particular challenges might be and see if we can look at some potential solutions. We also did a state comparison this year of 2 early supported discharge services versus non-ESD services. And whilst we can't extrapolate the data owing to it being such small numbers and state-based, it did show that significantly less active therapy was provided, and it definitely warrants a further look into ESD services and the need for all inpatient service models to offer an evidence-based level of therapy to promote recovery. Excuse me. So let's move on to how we're using evidence-based guidelines in practice. This element of the framework looks at whether there are documented processes and systems in place to support and monitor the routine use of guidelines in practice. So the use of evidence-based guidelines and participation in quality improvement activities have both dropped significantly since 2020. We've seen that in the data that the use of guidelines fell from 66% to 59%, and the involvement in quality improvement activities has gone from 86% in 2020 down to 75% this year. So these are two areas which are non-patient facing that have both dropped significantly. So it would be interesting to look at extra analysis and just see how much this data is influenced by the services with lower resourcing since COVID, and whether this has led to less ability to participate in activities that aren't directly patient-facing, like keeping up to date with the evidence and implementing it into care. We know that clinical care obviously takes priority when resources are pulled, so this isn't a great surprise, but it's still important to consider how we can maintain these processes. When we look at systems for transfer of care and follow-up, this really hasn't changed since previous audits and is probably indicative of larger systemic issues, like bed block, for example, or lack of appropriate community services, lack of resourcing in existing services, as well as the transfer processes themselves. So we really need to look at the whole bigger picture of rehab, what we've got, what we haven't got, and what we need before we can expect any shift here. So that's the org survey results completed. So let's move on to the clinical audit. So this is the data that's been taken from the patient records that looks at the care that's actually being delivered. So the first area that we'll take a look at is evidence that a care plan was developed with the team and patient, or the family alone if the patient had severe cognitive impairments on discharge. So from 2016 to 2020, the results really plateaued and they sat at 78% nationally. But you can see now that result has gone up to 83% in 2024, which is really positive. However, it does mean that 17% of patients missed out on this process, which is so key to supporting a successful discharge. I'd like to really mention South Australia here, who in 2020 reported 76% of their patients had a care plan that was developed with the team and patient on discharge. And as you can see, they've managed to increase that to 100% this audit. So congratulations, South Australia, you guys have made such a significant improvement. 77% of rehab services reported in the org survey that they've routinely provided a discharge care plan. But the clinical audit data showed that this procedure is not always being followed, or it's not being recorded appropriately by the clinicians in the case notes. As you can see on the slide, 66% of patients received a mood assessment. Of those who were assessed, 44% were found to have a mood impairment. The challenge for services, however, is that 1/3 of participating services did not have active involvement from psychological services in stroke rehab. So that's clinical psychology or neuropsychology. So the difficulty for staff is that once the patient has had their assessment, it indicates that they need further input, but they've got no services to tap into. So I think that's really challenging for the staff to deal with. When we looked at the matched data for mood assessment, and when we're looking at matched data, this is looking at the sites who have participated in all audits in the last 4 cycles. There's been a slow but a steady increase in adherence to this key indicator over those cycles, improving from 56% in 2016 to 67% in 2024. As I mentioned on the previous slide, the national result when looking at all participating services for this year is 66%. We know that patients are at greater risk of developing a mood impairment post-stroke, so these assessments are so crucial. Perhaps not surprisingly, the result was higher in specialist services where they're in a specialist stroke rehab unit, where 72% of patients received a mood assessment, compared to on a general or mixed rehab unit, where 63% of patients received a mood assessment. And again, I want to highlight South Australia here. Having achieved 89% of patients receiving a mood assessment, which really, as you can see on this slide, really stands out And I think it would be interesting to have further discussions with clinicians from these services to just find out how they are achieving it in comparison to other states. And again, this is a topic we're going to come back to in the panel discussion. It's definitely a hot topic in rehab at the moment. So much like mood impairment, urinary incontinence is also common after stroke, with 42% of patients in this audit being found to have had episodes of incontinence after they've had an assessment. But of that 42%, only 51% are then receiving a structured urinary incontinence management plan to promote recovery. So this is a really critical gap in an area that we know has such a massive impact on the discharge destination and patients' quality of life. So it is so important that this is addressed during their rehab admission. This slide is relating to the provision of information about stroke and recovery, such as the information contained in the My Stroke Journey resource. When talking to clinicians during the audit period, I was commonly asked if it counted if the My Stroke Journey book had been provided in the acute admission, so if it counted for this rehab audit, but it doesn't. As you can see from the slide, a significant proportion of sites are not providing this information during the rehab admission. Preparing the patient for discharge home after such a significant life event is essential, and nationally, 39% of patients are missing out on getting this information. It's unclear at the moment without further clarification if it's not being provided because it's an assumption that the information has already been given in the acute episode of care, or it is being provided during rehab, but it's not being documented in the notes. And most of the nation, as you can see, is at a similar level here, with South Australia and Tasmania leading the way. In the audit this year, 23% of patients were employed prior to their stroke, and only 61% of these patients were provided with information and advice on returning to work if they did want to resume employment after their stroke. In terms of information and support regarding sex, intimacy, and relationships after stroke, this continues to be poor, with only 25% of patients offered written information about the impact of stroke on intimate relationships, and only 18% being provided with the opportunity to speak to someone about their needs. Importantly, South Australia offered written information to 65% of their patients, and 42% of their patients were offered the opportunity to discuss issues relating to sexuality. And these numbers are considerably higher than any other state. So we reached out to them to try and find out why they are doing this so well, how are they doing it so well, when most other states are finding it so difficult. The feedback we received from South Australia is that they've worked really closely with a particular consumer to provide education to staff on how to approach this topic with patients. Staff have reportedly found this so valuable and have since been able to implement these new skills into practice. Depending on my time management skills, we may or may not have the chance to discuss this with a panel later in the webinar. But if we do run out of time and we can't bring it up for discussion today, it's certainly something that deserves more focus in the coming months as we start to really look at the priority areas in rehab. As we know, working with patients and their family to prevent further strokes is an essential part of the rehab admission. And as you can see in this audit, provision of medication on discharge remained pretty high overall. Prescription of antithrombotic medication was 90%, cholesterol-lowering medication 91%, and antihypertensives and oral anticoagulants for patients who had AF and ischemic stroke, both were sitting at 84%. When we look at the match data here, so again, these are the services which have participated across all those 4 audit cycles since 2016. The prescription of cholesterol-lowering medication and antihypertensive medication on discharge is at its highest level since 2016, which is fantastic. We do, however, need to look into the reason for the change in prescription of antithrombotic medication, as that's gone down from 97% in 2020 to 90% in this year's audit. So we would welcome your comments about this or anything else that we're talking about in the Q&A. So please feel free to make your comments in there. Moving on to look at whether the patient received education about behaviour change for modifiable risk factors prior to discharge. So we've just seen, we know that prescription rates for discharge medications are high on the whole, but education on lifestyle changes remains suboptimal, with only 68% of patients receiving the information that they need to understand and work towards lowering their stroke risk. For those who smoked or recently quit, just 47% received advice about smoking cessation, leaving more than half without the information needed to empower them to quit and seek support to stay smoke-free. In the matched analysis, the results for this indicator have dropped from 71% in 2020 to 67% nationally in 2024, while Tasmania have consistently achieved higher results for this indicator, achieving 89% in 2020, and as you can see, 92% this year. So some of the points on this slide I've already mentioned, but I just really wanted to pull together here the bigger picture of where rehabilitation services are at in terms of discharge planning. There's definitely more that needs to be done overall in this space to improve the discharge planning process and increase the likelihood of a successful discharge. Here we have a comparison of the key indicators when care is provided in a general or mixed rehab unit, which is the green columns, compared with a specialised stroke rehab unit, which is the blue columns. 30% of services reported having co-located beds in a geographically defined stroke unit, with only 8% of patients overall receiving treatment in these specialised units. 70% of patients were treated on mixed rehab units based on the clinical audit results. So we can see here that services with specialised inpatient rehab units were shown to provide a higher level of adherence to mood assessment, provision of education on modifiable risk factors, and development of discharge care plans compared to the general or mixed rehab units. And those, that just goes to demonstrate the value of the specialised stroke rehab unit. Mood assessment was the only indicator which had a statistically significant difference, with 72% of patients in the specialised stroke rehab unit being assessed, compared with 63% of patients in a general or mixed rehab unit. When we compare private rehab services versus public rehab services, there really isn't a significant difference that we can highlight here. The national data is in the green, the private rehab services in dark blue in the middle, and the public rehab services in purple. The number of episodes audited in the public units compared to the private units is vastly different, so we're really not able to draw any meaningful comparisons from the data at this stage. Now, don't panic. I know this is a crazy busy slide. We've tried our best to try and make this easy to see, but it's really just providing you with a snapshot of the data. So what this is basically showing is the data against some of the key indicators from 2016 to 2024 with the matched data. So you can see that's 49 sites who've completed the audit in each of those cycles. And this allows us to just draw some direct comparisons for these services. So there has been an incremental change in a few areas, but as you can see, there's no real great shift overall. And there definitely are some large gaps remaining, which is indicative of suboptimal care. And we did talk about it earlier in one of the earlier slides, but I just want to highlight the data that's sitting just to the right of the middle there, relating to the patient receiving information on sex and intimacy, which has remained well below 40% since 2016, with minimal change in that data. So we've made a number of recommendations based on the results of this audit for people and organisations at different levels of the system. I'm not going to read them all out. They go across this slide and the next, but you will be able to read them all in the national report when it's uploaded to the Inform Me website tomorrow. For government, we've recommended the development of a national rehabilitation stroke care standard. The state health departments and networks, we have suggested supporting services with the resourcing required to address the areas of concern that we have presented today. For hospitals and clinicians, the recommendations look at processes of care that are much in need of change, namely appropriate and holistic assessment and treatment, providing an evidence-based amount of therapy, and providing tailored information to support recovery in the hospital and ongoing into the community. So before we move on, I just want to acknowledge everybody that has contributed to this year's audit. So thank you to all of the health professionals who've participated. A massive, massive thank you. As a fellow health professional, I've said it before, I'll say it again, I know what a big deal this is. So I'm really grateful to you all for having put in so much work to get this audit completed. Thanks to the whole team at Monash who do the independent statistical analysis, and special thanks to Monique Kilkenny, who's been involved for many years, and to Catherine Burns, who did a remarkable job in analysing the results of the audit, and without whom I would not be able to present these results today. She absolutely went above and beyond in supporting me in particular, and I'm extremely grateful for everything that she's done during this audit. And as I mentioned, the full national report will be available to download tomorrow with any luck. All right, so I am going to stop sharing my screen in a moment so that you can see the panelists more clearly while they're speaking. And before we start the discussion, Natasha, if I could please come to you. As a long-time researcher, clinician and advocate for rehabilitation, I'd like to invite you to give your first impressions of the results of this audit.
Thanks, Anne. Undoubtedly, for me, the results paint a challenging picture for rehabilitation services after stroke. But firstly, before I speak to it, I do want to acknowledge the health professionals who work in rehab. You know, these are our people. And this report shows that we lost positions. The sector remains under-resourced, perhaps more so than ever. So these health professionals are working in an even more challenging environment. But that said, it is a great concern to me that the audit shows that only half of the organisations conducted an early assessment for rehabilitation services, and whether that means that organisations aren't aware of the benefits and value of rehab, or whether they are so under-resourced that they're not able to send rehabilitation clinicians out to assess people for rehab after stroke. It is disappointing because we know that assessment by a rehabilitation professional can impact on the rehab planning for that person, and it can change the trajectory for that person. So, you know, it's a key component of accessing care, and that's why that stat worries me greatly. The other startling finding for me was that only 13% of services have co-located their stroke rehabilitation beds in Australia, and only 8% of our audited patients received treatment overall in those specialised settings. You know, it's really challenging to develop yourself as a stroke clinician, and our team is a stroke expert team unless we co-locate the beds wherever we possibly can. And it looks like that's fallen off the radar for organisations. And I guess the other comment I would make, and probably unsurprising given my own research in this space, was it looks really disappointing to see that our ability to deliver the intensity of therapy that is needed after stroke again remains devastatingly low. The average therapy time staying at only 10 hours a week. You know, it needs something done quite urgently in this space in Australia. I know this is a wicked problem, but wicked problems need us all to work together. And hopefully this report is going to give us the data that we need for advocacy for change in this space. There's no doubt in my mind that we need to really seriously think about models of rehabilitation care delivery in our services. But to do that well, we need to all work together, researchers, clinicians, funders, as well as organisations. So that's sort of my high-level thoughts about this, Anne.
Perfect. Thank you so much, Natasha. I appreciate it. It's really valuable. All right, so let's get into our panel discussion. So we heard in the presentation that patients are receiving on average 10 hours of active therapy per week, as Natasha, you know, as you just highlighted as well, and even less in our early supported discharge services, which, as we know, is well below the current recommendation in the guidelines. So Natasha, I'm going to come to you first. Do you think this is related to the ongoing impact of COVID, or is this perhaps an issue of just the chronic under-resourcing?
Look, I think it's a complex problem. The reason I say that is there's no doubt that during COVID, hospitals that had an acute and rehab facility really prioritised acute care over rehabilitation. So we were told as rehab clinicians that we mattered less than the acute services, whatever they were. And we saw rehabilitation clinicians being seconded out of rehab posts and into acute posts. But we've also seen a rise in community rehabilitation through the NDIS, and we've seen staff leave for what perhaps might be, alternate workforce. But we haven't seen is a genuine attempt to re-establish levels of staffing to what they were before COVID. So I don't want to blame COVID anymore, because this is our normal now. We're well and truly out of that phase where staff were being seconded, yet we haven't seen them return to those pre-COVID levels. I think that what we have to acknowledge is that the standards for workforce that were released by AFRM quite a long time ago are woefully out of date. We do need some research conducted on what are the appropriate levels of staffing, so that we give organisations, an opportunity to start fighting for and auditing against appropriate standards and levels of staffing. But we also need to think laterally about how we do this. We can't still, as rehab clinicians, myself included, we can't still keep delivering rehab in the same way we used to when I first graduated. I'm not going to say how long ago that was. We can't do one-on-one therapy anymore. We have to think about, we've seen circuit classes and groups. We have to think about out-of-hours care. But the reality is, if I have a stroke tomorrow, I know what I want to advocate for myself or my family members, and that is a much higher intensity of rehabilitation than what's being delivered at the moment here in Australia.
Fantastic. Thank you so much. Tam, you've done a PhD in this area and have worked with your own hospital team on a number of strategies to increase the amount of therapy that patients receive. Could you maybe share with us some of the solutions that you found to be successful?
Sure, thanks, Anne. First, I just want to say, go South Australia. It's complicated, isn't it? So, as a clinician and a researcher, but definitely a clinician, I can see that it's really heavy. The patients are really high acuity. As Tash said, we're under-resourced, and I feel like we're also being asked to do more and more clinical and non-clinical work. So it is challenging. And Tash has talked about some of the big picture stuff, but I guess also I like to also think of it at the kind of patient level and the clinician level as well. So, to be innovative and engaging with our patients, we need to think about how we can, set up our programs and our interventions so that, it's fun and it's meaningful for the patient. So really spending time with our individual patients, getting to know that stroke survivor and what are their specific barriers and what are the specific things that make them who they are. I think we need to connect with people more so that they are more engaged. That takes time, obviously, which is a challenge. And then I think also we need to be thinking at the clinician level, and this is hard because clinicians are exhausted and they can't make all the changes themselves, so they really need that big picture support, advocacy from the system that they're working in. But of course, there are things that we can do as clinicians as well. We again thinking about how we deliver. So as Tash said, you can't be giving more by doing one-on-one therapy. We need to be thinking of clever ways we can be innovative and deliver services, whether it's in groups or other ways we can engage people more in, semi-supervised practice and open gyms and those sorts of things that we have talked about before, clinical champions. So all those things around innovation. I know that in the report you talked about and the specialist stroke education, but we know that for clinicians that's usually not enough just to change. If we want people to change the way we're doing things, just educating them is usually not enough. So we need to think about other strategies we can put in place. Is there some sort of incentivization or how we structure people's environments? So thinking about research around those sorts of things, I think would be great. We had just one example from my PhD, which was pre-COVID. So we had a group called Carers Count, which was just so much fun. So we had a music therapist involved. We had the carers come in, and the clients and the people with stroke and the carers all stood around the bars doing exercises together. So they had that modelling, they had fun because they were all choosing what songs they wanted to sing. They were having some healthy competition, and that was just so successful. So I think thinking about ways we can engage more and provide those services that aren't, kind of that traditional way is good.
Fantastic, thank you. Because I think it's been hard, hasn't it? With COVID, it's changed the way that we can involve the whole, the whole support network for that person with stroke.
Yeah.
It's become much more just about the person themselves, and I think it's, it was forced upon us, if you like, that we had to exclude family members and carers, and now we've got to find a way to bring them back in, I think, haven't we? So
yeah, absolutely. And we did, that group was on hold obviously during COVID, but we restarted it without the carers, but we still had that element of engagement with a music therapist and people being there driving each other and supporting each other. So yeah, but you're right, that did change.
Yeah, fantastic, thank you, Tam. So moving on to look at mood assessment, we said that we would come back to this one as part of the discussion. So Kelvin, you've obviously been involved in the Stroke Foundation audits for many years, and you've seen the ongoing challenges that clinicians have been reporting about, completion of mood assessments and then the subsequent access to psychology services. Why do you think we're still seeing this reported so commonly?
Yeah, thanks, Anne. Excuse me. Thanks, Anne, and thanks everyone for joining. It's really heartening to see the interest in understanding and how we can all improve. I think just touching on any change, so mood's a really good example, but any change is in rehab, it needs to be multidisciplinary, so the whole team needs to be involved. It needs to have the right people involved and the right processes. And that's just tricky when there's turnover of staff, there's clear gaps in the psychology workforce that we've got available in our teams. And some of the nuances, I think, about the timing around screening for mood. We all know that mood impacts, a third. The studies show at least a third in all phases of the rehab journey. So it's clearly a major need, and it clearly impacts on participation and rehabilitation outcomes. So it's critical. I was with the aphasia CRE last week, and just again reminded that communication deficits doubles the impact of mood and is a critical patient group as well. So I think we all recognise it's important. It's just getting the right person to lead it, to have agreement about what the actual screening is, so that early detection, and then a process to get a more thorough full assessment. And clearly, if we don't have a person available to do that comprehensive screening or the full assessment, why do the screening? If you can't actually offer them anything, why do it? So there's multiple factors, but we also know that there's been really good case examples of where this has been done well, where someone's in the team and the team has agreed that it's a priority and really looked at how their processes and implementing things that have made a significant difference. So like anything, rehab is about you guys, the clinicians, and the excellence that you bring to the person right in front of you. And so it's multifactorial. Part of it's people, part of it's process, and it's just the nature of it.
Thanks, Kelvin. Tam, in your experience as a physiotherapist, how have you seen mood impairment impacting on patient rehab?
Oh, I think it impacts massively. I mean, we can all just relate to that in our own exercise journeys. If you're feeling a bit flat, you don't feel as motivated to get out there and do things. But that link between low mood and low motivation is obviously very strong, and we know that hope is also a factor in there as well. But the problem is it's a bit of a vicious cycle, because if someone's feeling really flat, obviously people who have mood and depression post-stroke, it's more than just feeling flat. But if someone's mood is low, then they're not going to be participating in therapy as much, and therefore they're likely to kind of not maximise that window of opportunity to make more changes. So they are likely to probably have higher level of impairment and difficulty with activity and participation, which again would then impact mood more. So it's really, really connected to participation and involvement in rehab and hence outcomes, which again will then feed back into mood. So I think it's really massive. But on the flip side, if we can develop solutions, obviously the patients who are, we all have them, that are intrinsically motivated and driven, they will work to the maximal ability and have as positive an outcome as possible. So I guess we're coming up with some solutions around mood, because as you said, there's a lot of services that don't have that psychology support.
Absolutely. Thanks, Tam, which leads me nicely into asking you, Natasha, as a clinician on the ground, what do you think some of those possible solutions are to improve this situation?
Yeah, I think that probably we're at a stage now where we have to acknowledge it's unlikely we're going to see a rapid fix in workforce in the short term. But we can't really sit idly by and see this proportion of people who survive stroke make it into rehab and not be offered best practice, interventions. And that includes, obviously, not just the mood issue. This is to the sexuality. This is to the return to work. This is to the continence issue. We do have to start thinking about what does it mean to be a rehabilitation professional. At one of my units that I am lucky to work in, it is a specialised stroke and brain injury service. But we have a saying in the team, which is all care is everyone's responsibility. And there is a little bit of me that wonders if addressing this wicked issue of mood, for example, is that we've been relying on a change in education facilities to give us more psychologists and organisations to employ more psychologists to fix this. Instead, if I reflect back on how rehabilitation nursing played a key role, and that is obviously a specialised nursing workforce, but also, I think about the opportunities for us as health professionals to perhaps look at our ability to be a bit more broader in scope, or specialise in stroke in our scope of practice, rather than staying just in our silos of professions. Because if, as Kelvin said, if we don't assess mood, we can't possibly treat mood, because we don't know whether it's impaired or not. Scarily enough, though, we may be the only people for that survivor of stroke that they meet who has specialist stroke knowledge. They may never meet someone again who's ever treated somebody with a stroke. Their GP might not in the community, or their physiotherapist in the community might not be, or their social worker, if they're lucky enough to access one through community rehab, that might not be a stroke specialist. And so I do think we have to have a little bit of a reflection on our models of care, and unfortunately, yeah. Yeah,
I think you're right. Sorry, Kelvin.
I just want to come back into this conversation too. There's a couple of other things that is important to recognise. We did make a subtle change to the guidelines back in 2017, which may have taken back some of the impetus to screen everyone. And we made a subtle change to say people with potential. So if we pick up potential things, knowing that most of the multidisciplinary team are not the experts to diagnose mood, and I think in the acute space that's understandable because the length of stay is so short. But in rehabilitation, I categorically believe that everyone should be screened for mood, because, as we say, they're the higher acuity patients. They're much more likely to have the major mood disturbances. And if we can pick it up early enough, yes, there is also an issue around the diagnosis. So there's a 2-week gap that I've been told by the experts. You sort of need to wait sort of 2 weeks and then do a follow-up 2 weeks later. But I think it's the perfect place if we wait until they get back into the community, which again is another really critical point in the journey. There isn't, as Tash said, there isn't the workforce and the expertise to do it. So I'd be a strong advocate to say all of our rehab services should be screening at least, and then identifying a pathway to actually manage and do something about it if possible. So a couple of other nuances in there, but it actually absolutely is critical that we do this in inpatient rehab, because we know that the input once we leave the hospital system is scant.
And I think it's Natasha, you made a really valid point about services having limited access to specialist staff. We saw in the data 70% of patients are being cared for on general or mixed rehab units. And some of those units that I've worked with through the audit period, firstly, I think it's amazing that these units have put themselves out there and participated in the audit. Some of their admission numbers are relatively low, but they're wanting to improve the care that they are providing to their stroke patients. But they're often looking after a ward of a number of different patient types, and I think it's really difficult for them. I think we have to look at how can we support these units better, who don't have access to these specialist resources. It's kind of a situation, I think, of you don't know what you don't know. And I think we have to look at how can we reach out to those services and support them better so that they are aware of the guidelines, they are aware of the recommendations that are in place, and that the patients can receive the level of care that is recommended. I think it's really challenging in those smaller units in my experience.
I agree, but I couldn't help but notice in the chat that someone has put in there, and they're quite right, is that there were more co-located units in previous audit results. And so we could see that what is happening across Australia is that organisations are failing to advocate for that co-location of beds. So those stroke specialised opportunities for the beds to be co-located on one ward instead of split across multiple. If we don't all start to argue for this, if, I was previously part of clinical counsel, and when these results were first highlighted, my response to clinical counsel on behalf of OTs was to say to acute care clinicians and service directors to start arguing that they want to be referring their clients on to their inpatient rehab service that does have co-location. For those of us who've dialed in that are in a management type role or have an organisational leadership role within rehabilitation services, to start arguing for that. This might seem like it's outdated care, but it does allow us to mentor and support one another as we become more skilled in stroke rehabilitation. As our new graduates come out of university, they get to model behaviours of people who are working with stroke survivors regularly. And so I think that it's not just so much about the fact that there are more generalist units, it's that we're also losing where we did have the ability to co-locate beds, we're losing that even within bigger organisations as well.
Yeah, thank you. So it seems that my time management skills are pretty much on point today. So we do in fact have time to briefly talk about the issues around continence and sex and intimacy, which are so important. So Kelvin, we've seen that these have been really difficult to address. We saw the data for patients being offered information about sex and intimacy, that has just stayed low over the years. We're just not really getting anywhere in that space, except for South Australia. So, what do you think we can do? I know there's sort of bigger general change question, but specifically around maybe sex and intimacy, why aren't we addressing this? What can we do differently?
I don't know, I thought sex was sexy, right? Clearly not. But I look, all jokes aside, there is challenges in how we as individual clinicians feel about having those discussions and whether we feel that's appropriate or equipped or how we do it. And there's much more skills and training available now to better equip clinicians in this space. It's an interesting case study. So let's go to South Australia. So I actually know the one person with lived experience who's been a huge advocate for this, has been very vocal and has been attending essentially all of the state or a lot of the statewide education for clinicians. And she has effectively, I think, influenced. It's a consumer-led implementation strategy. It's an evidence-based approach that we actually as clinicians are influenced by clear cases from consumers. And I think that's a really interesting model and probably part of the picture in South Australia. I think there's obviously been recognition of the problem and taking leadership and a whole range of things. So having a focus is one thing, but it comes down to again, at a local level, the teamed approach is a commitment to do good quality care, which includes all of these things as we've outlined in the guidelines. And I think that should be non-negotiable. And so we, again, from a systems, because I just bring that sort of lens, from a systems perspective, we need, the right team members and the sustainability of and the certainty of the team and the processes to embed these as normal practice. And as I said, there is education and training now that is freely available. There's no real excuses. There's resources out there. Really, this indicator is actually not about speaking to the patient at all. It's actually whether you offered a piece of paper about information, right? So it's the easiest step in the process, and yet we're still not doing that well. So I think there is, a lot more discussion and a lot more training, but I think we as a collective group of rehab clinicians need to trust the process, trust the science, and trust the guidelines process, and then just get on and say this is the standard, this is quality care, this is what we're going to do for our patients, and make it happen.
Thank you. Tam or Natasha, did you have anything you want to add to that?
I just slightly off tangent around incontinence. So I think that you reported that only out of the people that were assessed for incontinence issues, only 51% then had a plan. So I think that's a huge area it's a little bit similar to mood, isn't it? That we, it's all well and good to assess it, but then if we're not doing anything about it, then that's not great.
I think across both of those, though, the piece of the puzzle that I would say is really important for us to acknowledge is that these are specialist stroke areas of practice. Not that you have to be a specialist to practice in them, but it is very confronting the first time that you raise sexuality, and that's not just return to sexual intercourse that OTs or physiotherapists may have a conversation about, but this is also discussions about what makes you feel close to your partner and intimacy, and that may be speech pathologists with loss of smell after stroke. It may be neuropsychologists or psychologists with changes in cognitive function and the relationship changes someone has. Or in the area of continence, it could be around managing your personal hygiene and how that has a flow-on effect. But most hospitals do employ continence nurses, and for those of us who are blessed enough to work with the amazing teams that we have who have a stroke specialist knowledge, getting those people involved and giving a person hope and comfort, it can make a really big change. I mean, I just also reflect on the amazing people I've had in my life who have taught me so much about the importance of those early conversations and being able to open up a conversation. I get your point, Kelvin, that this audit criteria is about a handout, but it is about more than that, isn't it? And, I can see in the chat, Louise Sellers from ACI has reminded us of the My Health Learning Sexuality module that New South Wales Health has put out. And, there is freely available education for us as clinicians to upskill. But also if we go into any of these conversations, just as humans, you know, and being open to saying, look, I don't have all the answers, but this is really important, and I am here as your clinician to help you find a pathway forwards while you're in rehab. I think that's really important for us to acknowledge isn't happening, and hasn't shifted for such a long period of auditing time, that we probably need to start doing a lot better, personally doing a lot better on this one, I'm afraid.
Yeah, thank you. Yeah, I think, you know, what it shows is there's definitely some key areas that need to be focused on going forward. We've had a really interesting discussion around some of those this afternoon, so thank you. So before we sort of finish off the panel discussion, the rehab audit results, the economic impact of stroke report that's recently been released, both of those have highlighted how much we still need to do to improve stroke rehab. Natasha, I know you've been working with some key stakeholders to drive improvements in rehab care. Can you just share with us sort of how you see stroke rehab changing going forward?
Look, there's no doubt we have a lack of rehabilitation data at a government level. You know, whilst we track acute beds in Australia, we track psychiatric beds, we do not track rehab beds in Australia anymore at a government level. You know, the belief in the effect that we have in the value of rehab has dropped significantly in recent years. We do know that that we can't tell you the rehab needs of people from an Aboriginal and Torres Strait Islander background. We can't tell you the rehab needs of people from a cold background. What we can tell you on the day of the audit is who is in beds across Australia, and for that I think we should be enormously grateful to the Stroke Foundation and their partners, because this audit does represent the largest amount of stroke rehabilitation data that Australia holds, followed closely, of course, by the AROC, the Rehab Registry data. But I do think that what we want to acknowledge is that we do have the guidelines that show how effective stroke rehabilitation is, and we do have a number of key areas that we track in the audit because they're effective interventions. And I think for me, that is the piece we have to hold on to as we start thinking about alternate models and different ways of delivering the value of rehabilitation, because of course it's not just an intervention that's delivered in an inpatient setting, it's also community-based, as we heard Tam talking about, it's family-driven, it's self-motivated as well. So, you know, I think we're going to see changes in models of care. We're going to have to see changes in models of care. But at the moment, I think we should all be advocating for, you know, a greater understanding of the value of rehabilitation, greater, you know, fighting for rehab services, not just rehab beds, but services, and better government data for helping track rehabilitation, which includes, as someone put in the chat, better data around workforce.
Fantastic, thank you. Tam and Kelvin, are there any final words? We've got some time to go through some of the questions that are in the Q&A, but before we do that, Tam and Kelvin, do you have anything that you would like to say? Tam, perhaps I'll start with you.
I think just reinforcing what Tash is saying, that, you know, we really want people to believe that if we're providing this evidence-based practice and we have these amazing guidelines, that we are going to make a difference. So that's around the services and advocacy. We've got the evidence, but we need to sort of develop and sustain innovative ways to deliver it and support the delivery of it. So that's at, you know, at the patient level, but it's really at the clinician level and who is supporting the clinicians as well. So it's that sort of, you know, culture of change, and which needs advocacy and support. And trying to think of some solutions, because we all know the barriers.
Absolutely, thank you so much, Tam. Kelvin?
Yeah, I think from my perspective, just the clinical work on the ground is amazing, and completely understand that we value, as Stroke Foundation, the amazing work that the clinicians do on the ground. A really important next step for us as the Stroke Foundation, knowing that this data really hasn't been shifting over many years, is for us and to take a much stronger look at how we can be advocating for systems level improvement and supporting the rehab community to really shine a spotlight of what we need to do to shift the dial and work with a range of stakeholders to really make that happen. So just for the record, we clearly have this in our sights in the next 3 years to really make a concerted effort to advocate and improve the systems for rehabilitation and to find some of the solutions to support you guys as busy clinicians. So the data is pretty stark, but we will use that as a springboard to dig deeper, to talk to the various stakeholders and really try and work with governments across the country to make a real difference.
Thank you so much. Thank you to all three of you for your input on today's panel. It's been really valuable having you able to comment on the results that we've seen today. So I really appreciate you taking the time out of your schedules today to participate. Thank you so much. We do have some time. We've still got a lot of people that have stayed online, which is fantastic. We did let everybody know we would be extending the webinar by 15 minutes. So we've got over 100 people still online. So we'll keep going if that's okay. Mel, can I hand over to you if there's any, if we've got some questions online that we could answer?
Yes, sure. Thank you, Anne. There are a couple of questions about the assessment for rehabilitation tool. I noticed, Tash, that you answered one of those. Would you like to share your answer for the rest of the participants?
So the one I answered was regarding whether or not the research shows that it has to be a medical professional who does the assessment for rehabilitation, and it doesn't look like it needs to be, but it does look like it needs to be a rehab professional. By that, what I mean is not necessarily an OT. I say OT just because it's my gang. An OT working in acute care who's not previously worked in rehab, but rather an OT who's familiar with what different rehab services can offer. You know, those early supported discharge services, what the community rehab services can offer, what an inpatient rehab service can offer. So that's really what strengthens that rehab plan, is insights into what rehabilitation offers and what the benefits are, the value, as it were. And that's not always apparent from, say, an acute care clinician who's not familiar with rehabilitation and the stroke guidelines.
Great, thanks. Thanks, Natasha. And another one for you as well. Do you have any specific recommendations for rehab assessment tools? Is everyone using the Australian Stroke Coalition tool?
Well, look, I am on the Australian Stroke Coalition, and I represent OT Australia on that, and we are suggesting that is the tool that should be being used. In terms of recent evidence to say one way or another, no, there isn't something that says if you've got a system that's working for your hospital and your network. It is really important that we understand the local landscape for rehabilitation options, though. I know they have become quite dire in more recent years, and that there are less and less community-based options. So it is about knowing what options are there, and there's no doubt across Australia that there are more options in some centres than there are in others. So it is, you know, it's about finding the right assessment tool for your service and the services you have available.
Terrific. Thank you very much. We have another question from Damian here. Has there been a reviewed staffing benchmark recommendation for stroke rehabilitation, taking into account consideration the burden of NDIS assessments and reporting? Kelvin, I'm going to pass this one to you.
So Tash mentioned there is staffing recommendations several years old now from the Faculty for Rehabilitation Medicine. We only just had a meeting of the Australian Stroke Coalition last Friday, and the various professional bodies and members of that national committee felt like this is a very important priority now. So we have agreed in the coming, or over the coming 12 months, to do a piece of work to at least try and provide some recommended staffing levels using as sort of robust a methodologies that we can, taking into consideration the evidence and what's recommended as good practice, but also patient factors, and because we know that there's slight variation in case mix between centres. So we will give it a go, and we hope to have some of that out. It'll come out for consultation. We certainly value the community's input sometime next year.
Kelvin, if I can add to that, you know, one of the things that I would like the rehab clinicians on the line to remember is just how powerful and how valuable they are. I say that because we finished a piece of work looking at the value of rehab and the cost savings of rehab. This was for a mixed ABI group. It wasn't just stroke only, but it did include stroke and other neurological conditions, including TBI. But the group came into rehab with quite a lot of rehab needs and what we might call quite, quite heavy patient caseload, hoist transfers. We had people who may otherwise have not made it into rehab. And for every dollar spent on rehab services, we saved $91 in ongoing care costs in the community. The work that we do across rehabilitation can substantially change where someone lives, who they live with, whether they get back to work, and that's that complexity. At a milder end of, and I don't mean mild in terms of it's not important, but with fewer impairments and perhaps a FIM score that is higher, we know that we make a difference in terms of return to work, in terms of mood, in terms of health-related quality of life, ability to go running again. At a more severe end with a lower FIM score, we know we make a difference in whether someone ends up living in residential aged care or not, and the life worth living at the end of the stroke. So that's that variability Kelvin mentions. You know, we have to come up with a staffing ratio that somehow takes into account those different case mix groups and isn't just about inpatient rehabilitation, is also about community-based rehabilitation. But that's the challenge that was thrown down by ASC to us all on Friday last week, as Kelvin mentioned. So, I guess I just wanted to add what an important job we all have in terms of delivering a life worth living after stroke, and that is the remit of rehabilitation. Yeah.
Terrific. Thanks so much, Tash, and that's a wonderful way to finish this audit results presentation today. And I'll just answer one more question. Yes, we will share the slides, and the recording will be available on the Inform Me website. So those will be accessible to all of you who've registered and attended today. So I'd like to thank you all so much for coming, and to Anne for an excellent overview of the audit results this year. Thank you so much, Anne. And to all of the panellists for sharing their time and their expertise with us. Very, very much appreciated. We've heard some really clear messaging today about the need for evidence-based rehab to become a must-have and not a nice-to-have, and the need to have action to change models of care and to improve stroke rehabilitation services in Australia. We've heard about the great challenges that clinicians and services are facing due to a lack of things like government level rehab data at the higher end, but also higher acuity patients, greater demands on clinicians, a lack of or loss of co-located beds, and multiple other things, including specifications about appropriate levels and of specialist staff to work in rehabilitation services. And it's great that that's something that's now got some attention and is going to be moving forward. And also, I think it's really concerning hearing about the impact all of this is having on clinician wellbeing. So, for the sake of our patients and for clinicians as well. This is something that has to shift. So we've also heard some great positives about innovations in states and individual services, and thank you so much, Tam, for sharing some of what you've done as well in your research and practice. Kelvin mentioned that Stroke Foundation is really keen in 2025 to work more in the advocacy space and ensure that processes are in place to capture the data required to properly monitor care. And we're also keen to work with networks and clinicians as well to get that data into processes of care. So whether Stroke Foundation delivers the next audit or whether something will be done by another organisation is part of that conversation, but we will update as we move forward with the broader conversation about how we can make the shift. So on a final and very sad note, Anne is finishing up with us next week, and so I'd like to take this opportunity to wish her the very best and just to thank her for being the absolute best of colleagues, having done a brilliant job and being a wonderful human to work with. So thank you so much, Anne. You're much appreciated. Hope everyone here has gained some great insights today and enjoyed the webinar. Thank you again for joining us, and take care.